everybody. This is Dr. Brett Talley Daniel, MD, and I'm a neurologist and headache doctor. And today I'll be talking about the subject of when to start acute migraine therapy. Migraine headache occurs in 12% of the American population. 25% of women and 6% of men have migraine headache. Migraine headache is the 5th most common cause of disability and the 10th most common cause of a visit to the emergency room. The 3 most painful conditions known to men are migraine, kidney stone, and childbirth, and that's really only known to women, as everyone knows. So when to treat migraine headache? Migraine headache should be treated at the onset of headache pain with a triptan. Migraine headaches have 4 phases: prodrome, aura, the attack, and postdrome. Migraine patients should either treat at prodrome, the onset of aura, or the onset of the headache attack. The prodrome may come 24 hours before the attack occurs and may consist of fatigue, drowsiness, food cravings, depression, irritability, trouble concentrating, phonophobia, and increased urination or diarrhea. If these symptoms can be recognized by the patient as common and reliable occurring symptoms before the attack occurs, then the patient should treat before headache occurs at prodrome with a triptan. If a migraine with aura patient has a visual aura before the headache starts, then the patient should treat at the beginning of the aura with a triptan. Migraine visual auras usually last 20 to 30 minutes, but can be as long as an hour before the headache follows. Treating at prodrome or aura means the treatment is early and the drug use is more likely to succeed. The problem is some patients have their aura at the same time their headache starts, and these persons should treat at the onset of their aura, which comes at the same time as the start of the headache. Some patients have their aura near the end of the attack of headache, but they should have treated at the beginning of the headache. Only migraine headache patients have the altered brain neurophysiology that leads to the headache, so that 94% of men and 75% of women who do not have migraine do not have these physiologic changes. Only migraine patients do this. The migraine process releases 3 different neuropeptides, and these chemicals cause arterial dilatation and inflammation of the trigeminal nerve, the arteries, and the thalamus. Triptans, if taken early, will stop this stage of the migraine process. Over-the-counter drugs do not do this. That's why triptans, which came out in 1991 as injectable Imitrex subcutaneous 6 milligrams, have been so successful and important for treating migraine all over the world. It can be said that 80% of persons who treat their migraine at the onset of headache, as outlined above, may be headache-free in 2 hours. Comments regarding the available triptans. General triptan rules. Do not use with a personal or strong family history of coronary artery disease. Do not use with uncontrolled hypertension. Limit the dose in children, the elderly, defined here as over 65 years old, and patients with basilar artery or complicated migraine, that is, aura symptoms that last over 60 minutes. Do not mix the triptans or take with ergotamine within 24 hours. Common symptom side effects are chest tightness or pressure, near fainting, back pain, which may be burning, a warm or hot feeling, dizziness, or drowsiness. Sumatriptan, Imitrex now, is the most effective when given via a gun type of injector. I've got a list on my webpage at www.migraine.com of all these different drugs. So there's Imitrex, which is sumatriptan, Zomig, which is zolmitriptan, Maxalt, rizatriptan, Axert, which is almatriptan, Relpax, which is elytriptan, Emerge, which is nartriptan, and Frova, which is frovatriptan. There's 7 triptans, and 5 of them have onset for treatment and to work in 30 minutes. The drugs that take 1 to 2 hours to work are Emerge, are naratriptan, and Frova, which is frovatriptan. Also, Emerge and Frova are long-lasting So Emerge lasts 6 hours, whereas Frova lasts 26 hours for half-life, and it's a good drug for menstrual migraine. So I've got a list of all the drugs and there's time relationships on my blog. Now, here's a thing I call the migraine timing cycles, and there are 4 steps in the migraine process with part of this cycle. The first step is trigeminal inflammation by the brainstem. Then the second step occurs at 20 to 40 minutes as the ganglion of the nerve and the artery of the brain starts to release neuropeptides, which are neurokinin A, substance P, and CGRP. Then at about 2 hours, release of these chemicals causes the third step of the migraine cycle, which is meningeal artery vasodilatation. And the fourth step at 3 to 4 hours, when the headache really gets bad, which is inflammation of the thalamus, a deep nucleus in the center of the brain, which is called the pain center of the brain. The fourth step is also called, in neurology talk, central sensitization, because steps 1 and 2 and 3 occur in the skull, but are outside the brain. The trigeminal nerve, the nerve and arterial ganglions and arterial arteries are in the skull, but they're not part of the brain itself. Step 4, though, inflames the thalamus, which is a deep nucleus inside the brain itself. Migraine is defined by the International Classification of Headache as lasting 4 to 72 hours, and this is not done for some trivial, abstract, academic reason using 3 days or 72 hours as the time a migraine may last, but rather because that's how long these inflammatory neuropeptides stay in the body. They come into the brain, they drain down the veins to the liver, and are discharged in the toilet after 3 days. If one treats migraine with over-the-counter drugs like Advil or Tylenol, they do not stop the release of the neuropeptides and the inflammation. Yet triptans will do that, and that's why they are such important and effective drugs for treating migraine. Patients with migraine should treat with triptans, but never with opiate drugs or drugs like butalbital, like Fioricet. Butalbital is a barbiturate drug, and in my opinion, the worst drug in the world that causes medication-induced headache. And because of this, it has been banned in every country in the world except Canada and the United States. I'm talking about butalbital. The use of this drug in America is a political issue to be resolved by legislatures, and so far, neurologists and headache doctors have been unsuccessful in eliminating the use of it. Caffeine, Tylenol, Advil, Aleve, and triptans can cause medication-induced headache if taken too much. The general rule of migraine patients to prevent medication-induced headache is to limit over-the-counter painkillers and triptans to no more than 2 days a week. Medication-induced headache is the current term for persons who have chronic migraine from overuse of medication. It used to be called rebound headache, which is an old term. Chronic migraine is defined by the International Classification of Headache as being 15 headache days or more per month, 8 of which have migraine features. Episodic headache is defined as 14 or less headache days per month. If the patient uses over-the-counter medications or a triptan, a transition occurs so that after several migraine headaches have occurred within a week or 2, every time the patient takes caffeine or Tylenol or a triptan, the inflammatory neurochemicals are released and they stay in the body for 3 more days, and so the migraine process becomes continuous. It's sort of like putting lighter fluid on a fire, which makes the fire continue to burn. If one considers that migraine can generate chemicals that last 3 days, and multiply that by 2 days, the result may be 6 days of neurochemical release per week. So if the doctor allowed the patient to take Tylenol or triptan 3 days a week, that's 9 days of chemical inflammation, more than the 7 days a week, and that explains the limitation of all painkillers and triptans to no more than 2 days a week. I have a more thorough discussion of the migraine timing cycle on my webpage at drmigraine.com. And just click it and you can go there and read about that. Now, headache-free means that all migraine symptoms are gone with treatment of the triptan early. So headache, nausea, sound sensitivity, light sensitivity, olfactory sensitivity, mental cloudiness are all gone. In my office, I go over and over again this point with patients to treat early, and then the next time they come in, they report many times they did well with the triptan and the migraine was gone early. Many patients tell me they get relief within 15 or 30 minutes, which is less than the reported time it takes a drug to work as published by the FDA. Now, there are acute treatment migraine drugs that have come out for 2020, and these drugs are Nurtec, which is rimegepant, Ubrelvy, which is ubrogepant, and Rayval, which is lasmiditan. Well, how well do these drugs work? How well do these drugs work in comparison with triptans? The drugs just come out. We don't have any data that's been published, but these three drugs decrease the symptoms of migraine attacks and improve function compared with placebo. They may be helpful for the 20% of patients who are unable to take triptans. In my opinion, still considering triptans are the best drug for treatment. How do these new drugs work? They're all oral drugs. Nurtec and Ubrelvy block the CGRP receptor, and CGRP is one of the inflammatory neurochemicals released by the migraine process. Rayval works on 5-HT1E receptors, which inhibit trigeminal nerve pain pathways. Rayval also inhibits release of neurotransmitters and neuropeptides. Rayval does not cause arterial vasoconstriction like triptans do and can be used in patients with heart disease, stroke, and hypertension. What's the expense of these new drugs? Both sumatriptan and iliatriptan, which is Relpax, are less expensive and more effective than these newer drugs. Nurtec is administered as a fast-acting, orally disintegrating, single-dosed 75 milligram tablet in a patient with episodic or chronic migraine. One study demonstrated a statistically significant reduction from baseline in monthly migraine days in individuals treated with rimegepant or Nurtec in comparison with placebo. Treatment provided pain relief within 1 hour. Nurtec had a sustained efficacy of pain relief lasting as long as 48 hours for many patients. This is an unusual drug, Nurtec, that works quickly for acute therapy, but has also been approved for episodic and chronic migraine prevention. The next drug here, the new one, is Ubrelvy. And 20% of patients who received 50 or 100 milligrams of this drug orally had freedom from headache pain in 2 hours. The FDA approved Ubrelvy for acute treatment of migraine. It has no effect on vasoconstriction and is okay also with heart or stroke conditions. Rayval, lasmiditan, is the first and only what they call DITIN, D-I-T-I-N, for the acute treatment of migraine, with or without aura. Rayval is not indicated for the preventive treatment of migraine. Dosing. Take 3 oral dose sizes of Rayval, and they exist. There's 50, 100, and 200, but only one dose should be taken in 24 hours. A single dose of Rayval may cause significant driving impairment due to increased sleepiness lasting as long as 8 hours. Therefore, because of this possible side effect, patients are advised to not perform potentially hazardous activities requiring complete mental alertness, such as driving a motor vehicle or operating machinery for at least 8 hours after each dose of Rayval. Well, boy, I can see my office. I wouldn't be able to give that to many of the office patients I have. They have a migraine at 4 o'clock in the afternoon. Their drug lasts 8 hours. They can't drive home. They have to take a taxi or Uber or something. Rimegepant and ergopant both block CGRP activity, while lasmiditan is a serotonin H5HT receptor agonist. All migraine patients who do not respond well to triptans, and that's about 20% of patients, should discuss these new drugs with their neurologist. Now, I have some related questions about this subject. So why don't patients treat their migraine early on with a triptan? Number 1, hoarding. Patients only get a limited supply of drugs every month, and they don't want to run out. I've got to save them. It's the end of the month. I've only got 1 Maxalt left. Insurance companies limit sumatriptan 100 milligram tablets to only 9 per month. Some insurance companies will only give 2 triptans per week, and if I write 10 per month, the patient has to go back to the drugstore every week to get a prescription filled. That's a real burden. One study found that 37% of patients with insurance plans that limited the number of triptans per month didn't treat with their triptan at the onset of the migraine and had more ER visits for headache per year than patients without insurance, which is 79% in this study, who are more likely to take their medicine at the onset of a headache. So another reason why people don't treat early, expense. With insurance, there now is a copay of $10 to $40 per prescription for a triptan, which can add up if the patient's taking several drugs. However, all these triptans are generic and cheaper than some name brand, and they're cheaper than the new drugs I just mentioned about that came out in 2020. Patients can sometimes find coupons online that are a better deal than using their drug insurance plan. Another reason, nihilism. Nothing works. Many migraine patients have ingrained previous experience that nothing will work. These are the migraine patients who have been using the over-the-counter meds, opiate narcotics, and butalbital for years and have developed medication-induced headache, and triptans don't work in that situation. Nothing works in this situation except DHE, or getting off the drugs they're taking. See my article on my webpage at medication-induced headache. This group of patients with low expectations that anything will ever work includes migraine patients who have been prescribed triptans but were never instructed to treat at onset and when early and mild. When these episodes come, episodic migraine patients finally try their triptan early, the same drug they've always waited to use, they're pleasantly surprised with how well the drug works. They come back for their neurology recheck visit with a smile on their faces. They just never knew how to treat their migraine. Number 4, fear of overtreatment. I don't want to take too much medication. Experienced migraine patients know if they take too much medicine a day, it may, like the snake on the ground that you try to bash on the head, rise up and bite you on the leg, resulting in more headaches. In general, one is only supposed to treat a headache 2 days a week, as I said before. And that's also the same rule for over-the-counter, for coffee, for the over-the-counter NSAID drugs, opiates, and triptans. Each of the triptans has an individual total maximum recommended dose per 24 hours also. That's on the product information. Lawrence Newman, director of the Headache Institute at St. Luke Roosevelt Hospital Center in New York, speaking in an interview with Primary Neuro News in 2007, was asked the following questions. Or here's a headache guy was asking this question. If you had a single piece of advice you could give to every healthcare professional treating patients with episodic migraines to ensure that fewer of their patients with migraine would progress to chronic daily headache, what would it be? Dr. Newman's response was, quote, to limit the number of acute medications that they're re-giving at one time, not to be liberal with refills, so that you keep a close watch on how many medications patients are using and initiate preventive treatment in appropriate patients. If you do that, you can proactively, in many patients, prevent medication-induced headache and the progression of the disorder, end of quote. Number 5, concern for side effects. The triptan treats the migraine, but the patient dreads the side effects, the chest tightness or pressure, near fainting, neck and back pain, which may be burning, warm or hot, drowsiness or dizziness. This is where the treating doctor should explain that triptan side effects are not serious. Many patients hearing this will gladly tolerate a mild side effect for a miraculous drug that treats a bloody migraine. These patients should be instructed that triptan side effects are dose-related and sometimes merely decreasing the dose, like going from 100 milligrams sumatriptan to 50, may avoid the side effect. If that doesn't work, then that patient is due for a trial of a different triptan, and there are 5 acute onset drugs which work in 30 minutes. Also, patients who switch to another triptan 60% of the time, that'll work, period. Everybody's always asked the question, which was the best triptan? And it's really never been published because once we had all the drugs out there, some pharmaceutical company would have to fund a drug costing several $1 million, and somebody would win or lose, so they never did the research to do this. But finally, several years ago, the American Academy of Neurology Headache Group said that they thought the best triptan was the original one that first came out, brought out by Glaxo in 1991, which is injectable 6 milligrams Imitrex or sumatriptan. And that's the best drug because it works quicker in 10 minutes and gives a higher level of medication in the brain. All right, number 6, another reason, waiting. I just wanted to wait and see if it would go away. I wasn't sure it was a migraine. Sometimes they go away on their own. I was waiting to see if it's going to be one of those, and usually it is. This is the old, I want to wait to see what happens with this headache game of Russian roulette. Patients play, which is unproductive and usually self-defeating. They wait and they lose. Migraine sufferers should consider that 57 to 77% of patients take a triptan early or headache-free at 2 hours. Dalhoff and Mellberg from the Gothenburg Migraine Clinic in Sweden were quoted in Neurology Reviews in 2007 as finding, quote, a substantial difference in total pain in early versus late treatment with triptans, end of quote. Overall, the total patient pain during the 72-hour follow-up period was lower after early treatment. All right, another a treatment reason why people don't treat early is ignoring nighttime migraines. I woke up at 4 in the morning with a headache. What can you do? I just rolled over and went back to sleep, but I had a terrible wake-up headache in the morning. This is a nocturnal headache coming at the end of a rapid eye movement event called REM sleep event. Many patients with headaches like this wake up in the morning with the migraine still there 2 or 3 hours later. They are already at stage 4 in the migraine process of central sensitization, and the triptans don't work well then. These early morning migraines last all day and sometimes into the next day. These patients should be instructed to sleep with their triptan pill open and available on the tablet with a glass of water next to their bed so they can sit up briefly, take their medicine early, then go back to sleep. Also, injectable sumatriptan or intranasal sumatriptan or zolmitriptan may help nocturnal headaches because they work in about 10 minutes as opposed to 30 minutes for the other acute onset triptans. This is how to treat nighttime headache at the onset when early and mild. Number 8, excuses. I was at work and left my medicine at home. I was in the middle of an important meeting. I was driving to work in traffic. It rained and the freeway backed up. I had a deadline to get a project finished that day, and I couldn't do anything else. I couldn't even eat lunch. My dog ate my medication, my term project, my homework. These are patients who haven't faced up to the reality of life. Migraine is a chronic problem. It's genetic and part of the genome. The possibility of getting a migraine is always there, particularly if there are aggravating factors: stress, menstruation, barometric pressure change, skipping to meals. The Boy Scout motto is, be prepared, and migraine patients need to be Eagle Scouts. The patient needs to have their medicine with them at all time. Attack could come anytime. Get a grip. Treat with a triptan at onset when early and mild. Mild migraine headaches may be treated with over-the-counter drugs such as caffeine, Tylenol, which is acetaminophen, Advil, which is ibuprofen, and Aleve, which is 9%. But more severe migraine headaches should be treated with a triptan, and triptans are the best drugs for acute migraine therapy. So this is a dictation I'm finished with on when to start acute migraine therapy. I hope it's helpful to everybody. Please click on subscribe down there. Follow me on Podbean or Spotify for other podcasts I've had on migraine. God bless all you persons with migraine, and I will see you on another talk.